Hi guys, welcome back to the channel. We have started with odontogenic carcinomas. We have dealt with one. Let's start with others. Primary intraosseous carcinoma de novo. Last time we have studied primary intraosseous carcinoma ex odontogenic cyst. It is carcinoma de novo. Clinical presentation and pathogenesis. Present as a more clinically aggressive and radiographically destructive radiolucent lesion in which the border with adjacent bone is irregular and jagged type of root resorption. Paresthesia and anesthesia are common with this tumor. Histopathologically, a central epithelial malignancy of the jaw, no clinical or histological connection to an odontogenic cyst or overlying mucosa, usually represents squamous cell carcinoma and often exhibit keratinization. Histology may be difficult to distinguish from ameloblastic carcinoma. Okay. The primary intraosseous carcinoma ex odontogenic cyst, in that we have studies that is related to cyst and cystic grafting. This de novo is not related to cyst or overlying mucosa. It is a central epithelial malignancy and it is more aggressive and more destructive. Now coming to third, that is malignant ameloblastoma. Clinical presentation and pathogenesis. Most commonly will present as a multilocular radiolucent jaw expansion typical of benign ameloblastoma, but with a concomitant metastatic focus usually in lungs. Okay. It present as a benign neoplasm but has a metastatic focus usually in lungs. Now, type of root resorption suggestive of benign process. Paresthesia may or may not be seen. Metastatic focus is often discovered on routine chest radiograph or may be found by a site-specific complaint. Represent a jaw tumor that is benign ameloblastoma histopathologically but has metastatized to a distant site or to a regional lymph node. It is very important in this. It is a benign ameloblastoma histopathologically but show metastasis, exophytic growth and intraneural invasion. Now coming to the last type, that is ameloblastic carcinoma. It differs from the malignant ameloblastoma in the following features. First, the pre-ameloblastoma are cytologically atypical, whereas in malignant ameloblastoma they appear cytologically benign. Okay, in ameloblastomic carcinoma it is cytologically atypical. Second, the ameloblastic carcinoma may be locally aggressive and undergo regional lymph node metastasis, but this is not required to show or to confirm diagnosis. But in malignant ameloblastoma must show metastasis to confirm the diagnosis. Okay, these two are the major difference between ameloblastic carcinoma and malignant ameloblastoma. Now, ameloblastic carcinoma are usually large tissue masses with ulceration, significant bone resorption and tooth mobility. Behavior is similar to that of an aggressive squamous cell carcinoma, histopathologically identifying the pre-ameloblastomic cellular atypia. Unlike malignant ameloblastoma, this tumor shows cytologic features of malignancy, that is hypercellularity, cellular atypia, hyperchromatism and mitosis. Diagnostic workup, incisional biopsy, removal of cysts, surprise finding मिल सकता है. Staging workup consisting of neck examination, a CT scan of the area, a chest radiograph is necessary. There is an intraosseous tumor and T4 lesion by location. Assessment for nodal metastasis and evidence of distant metastasis is required. Okay, these diagnostic workup is for generally or mostly for all the four types. Okay. Treatment: jaw resection with 2 to 3 centimeter bony margin and an in continuity neck dissection, both prophylactic and therapeutic. Okay, this treatment plan is also for the all four type. Post-surgical radiotherapy is also a consideration. Chemotherapy, selective site radiotherapy or cyber knife radiosurgery. Okay, that's all for today. Till then, like, share, subscribe and comment. Bye.